All right, I think we can go ahead and get started. We did just want to take a minute to thank you all for coming out. I know as first-year med students, you have pretty busy schedules, so we really appreciate you taking the time to come talk with us. And again, today we're going to be talking to you specifically about the anatomical development of the oral, nasal, and pharyngeal cavities, specific to newborn sucking and swallowing. But before we jump into that, I do want to take a moment just to introduce my team. So this is Megan Basical, I'm Kelsey Hines, this is Mike Scott, and that's Sydney Carlson. And today in our presentation, we are going to specifically cover some specific developmental impairment examples that might contribute to infant dysphagia. We're also going to go ahead and talk about the speech-language pathology recommendations that we would make to address each of those impairments. We're going to provide you all with some information about what to look for in the event that you do suspect an infant has dysphagia. And then we're also going to talk a little bit more about what to do in the event that you suspect an infant has dysphagia and why we would go about doing that. And then to wrap things up and conclude, we're going to provide you all with a pocket reference that can be used for quick, easy identification. You can have this post-infant delivery at bedside, and this will provide you information about infant oral, nasal, and pharyngeal structural abnormalities. So to begin, Sydney's going to talk a little bit more about the development of these specific cavities.
So first we're going to start out talking about the development of the oral cavity. So in a newborn, the oral cavity is very narrow and small, so the tongue will fill that entire cavity. The floor of the mouth is also very underdeveloped. The oropharyngeal structures are compressed, but they will separate with time and growth. And I'll speak more on this when we discuss the pharyngeal cavity development. Babies are also born with large cheek or fatty pads. They provide stability for the jaw and they maintain oral pressure during feeding. This means there's no buccal cavity. These pads will reduce with increased coordination of cheek muscles and sucking, swallowing skills. Dentition eruption also begins around 6 months old in babies. So next we'll talk about the nasal cavity. The infants are nose breathers because that oral cavity is too small. So like I mentioned earlier, the tongue takes up that entire cavity. So nose breathing is a necessity to facilitate suck, swallow, breathe synchrony in infants. So as the newborn develops, he or she will eventually lose this ability to simultaneously suck, swallow, and breathe. But it is necessary right after birth. The eustachian tube is also horizontal, and that angle of feeding and breastfeeding or bottle feeding is very protective. So next we will talk about the development of the pharyngeal cavity. So in newborns, the larynx is very high in the neck. This provides extra protection of the newborn's airway. The pharyngeal cartilage is soft. It supports growth. As we know, newborns have a lot of growing to do. The oral pharyngeal structures are compressed. So like I mentioned earlier, the mouth and throat structures, like the soft palate and epiglottis, are in very close proximity to each other, and it limits the amount of open space in the mouth and the throat. So this is very protective and acts as a natural protection from aspiration as the newborn swallow develops. So as the infant grows, the structures will spread out and the open space will increase, so the throat will become larger. This structure, all these cavities as a whole, is adult-like by 3 years old. By 4 to 6 months of age, the structure is no longer protective, so that structure lengthens out. The larynx drops and those structures separate. So this is a child to adult comparison, just to kind of give you a better visual.
Okay, so we are going to give you two very specific developmental impairment examples of what can happen if an infant has dysphagia or something that can cause them to have dysphagia. So number one would be silent aspiration due to an absent cough reflex. So as you may know, aspiration is when food or liquid escapes to the larynx instead of going down the pharynx and the esophagus. And silent aspiration occurs when the individual does not cough or make any attempt to clear their airway. And so an infant may have silent aspiration due to an absent or underdeveloped cough reflex. And what an SLP may do for treatment is they may facilitate a gag reflex in order to develop that cough reflex. And this is done by having the clinician or parent apply gentle pressure to the back of the tongue to initiate and stimulate that gag reflex using just their pinky finger. And that gag reflex is going to help strengthen the musculature, and that's going to help build pressure that's necessary for an infant to cough. You're also going to want to test other reflexes for the infant to see if there's a neurological component. there is, you're going to want to refer them to a neurologist to get tested. If you also want to treat the aspiration component, which we do, you can modify the infant's diet by perhaps thickening their liquids, but not too much. And you may also change the size of the nipple that's on the bottle, and there's definitely other things that you can do with that.
Absolutely. So along with the absent cough reflex, another abnormality that could be commonly seen in infants would be it's ankyloglossia. So what that is, it's tongue-tied. So ankyloglossia, or tongue-tied, occurs when the frenulum, or the tissue band that connects the tongue to the floor of the mouth, is short in length, causing the band to be tight and restricted in movement. So some quick assessments that you can do on infants that will show the tongue-tied would be to have the baby imitate you. So what you're going to do is you're going to stick out your tongue with hopes that the baby will imitate you. And what you're going to want to look for is a heart shape at the front of the tongue. So if we could show that video real quick, Naga. So what this looks like, as you can see here, the frenulum is cut short and it shows the nice heart shape of the front of the tongue, which is indicative of the tongue-tied. Great. So another assessment that you can do is you can put your finger pad side up. To initiate the suck, you're going to put it right into the baby's mouth. And what you're going to look for is the baby's ability and strength to stretch the frenulum past, or the tongue past the gum line to cup the bottom of the finger. So some common concerns with infants with tongue-tied are, number one, the feeding technique. So there's a study done for tongue-tied and non-tongue-tied that concluded that some, but not all children with tongue-tied will have difficulty latching on to the mother's breasts. However, some of these babies don't have this difficulty when it comes to bottle fed. So with breastfeeding, the mothers will see prolonged feedings, increased pain, and less milk production, and the babies will produce a more noisy suckling noise, and some gas pains may occur. And then later on, you may notice some development in speech delays. So now we're going to talk about some recommendations for infants with tongue-tie. So first we'll start out with non-surgical. So as I mentioned before, some babies do better with the bottle fed, so you could just ask the mother to, rather than breastfeed, bottle feed. Some more recommendations would be to perform exercises to strengthen and improve the function of the facial muscles, which will then promote proper function of the face, mouth, and tongue muscles. When we're looking at speech, as I mentioned later in infancy, compensatory strategies that could be used for speech mobility and the n, t, d, and l sounds would be dentalization, which would just bring the tongue forward and up. More compensatory strategies will be used on different sounds. Moving on to surgical would be the frenectomy, which is cutting the frenulum to reduce the tension of the frenulum. And then lastly, there is a wait-and-see approach. Between the ages of 6 months and 6 years, some frenulums will naturally recede, and in that time, you could always use the non-surgical approaches.
So we've provided you all with some pretty specific examples of developmental impairments. And at this point in the presentation, we'd really like to just take a step back and take a broader perspective when we're talking about infant dysphagia. So in order to do that, we wanted to talk with you all a little bit about the abnormal swallow. So let's talk a little bit about what the abnormal swallow is and how it is going to interfere. So an abnormal swallow is going to interfere with airway protection, nutrition, hydration, and also just the overall enjoyment of the feeding experience for both the infant and the caregiver. So observation is really key when we're trying to determine if a swallow is normal or abnormal. So what would we be observing? What are we looking for? What are the signs and symptoms? So we've provided you all with a pretty extensive list of some signs and symptoms that may be indicative of an abnormal swallow. I will, just for the sake of time, touch on a few. So you may notice that the baby is arching their back. You may also notice that they are coughing frequently either during and or after mealtime. They might be stopping frequently due to that uncoordinated suck, swallow, and breathe pattern. You might notice that they are taking multiple effortful swallows, and you might notice that they have either a noisy or wet vocal quality during or after feeding. And then weight loss is another sign and symptom that we want to be paying attention to, or just the lack of appropriate weight gain. So now let's talk a little bit about what to do in the event that you do suspect that an infant has dysphagia. So what we're going to want to do is go ahead and refer for a comprehensive swallow assessment, and a team approach is ideal. So who would be on the team? Ideally, we would have an SLP that specializes in swallowing and feeding. We'd also want to have a physician on board, a registered dietitian, a lactation consultant, a nurse, and potentially even an occupational therapist or a physical therapist. So now that we know a little bit more about the team, we can talk about what to do in the event of a suspected dysphagia and why we would take those steps. So we want to go ahead and examine things like posture and positioning. And for example, that would be important for us to look at further because it might help us with some compensatory strategies that we could use later on during treatment. We'd also want to look at things such as heart rate and respiratory status. We'd go ahead and do an oral peripheral exam. That's going to provide us with some information about any structural abnormalities that might be contributing to the dysphagia. We'd also want to examine the non-nutritive suck, the nutritive suck, and breastfeeding. And again, we want to look at each of these factors because they're going to provide us with a really comprehensive picture of the physical and emotional state of the infant, which we know is essential when we're assessing the newborn swallow. So at this point in the presentation, we'd like you all to pull out your pocket reference that we've created. It should be in your information binders, and we can go ahead and have you all take a look at that. And again, this is just going to be a tool that you can use for quick assessment of structural abnormalities. And once you guys have had the opportunity to take a look at that, I think at this point in the presentation, we can go ahead and open things up for questions. So what questions do you all have for us?
Thanks for watching, guys. Bye.
Bye.